Alrighty, so we are in our rotation of the 8 topics for the Mentor Echo. So this is the Formulations of Buprenorphine week. So some of you have seen this in the past. So objective-wise, just looking at the available buprenorphine-containing preparations, administration differences, because they are a little bit different than our traditional dosage forms, and then looking at some of the pharmacokinetic differences. One thing I just wanted to mention before we talk about the specific preparations, buprenorphine was included in the FDA statement about they're not getting rid of any of the REMS testing or monitoring requirements, but they are not necessarily enforcing it at this time. So their official statement came out, I believe, March 22nd, that talks about they recognize the difficulties of getting any type of imaging or laboratory testing because of the possibility of transmission of COVID-19, or for individuals who do need to self-isolate or are on quarantine, easy for me to say, that may increase the risk of transmission to themselves or to other individuals. So at this time, they're not necessarily enforcing any of the laboratory requirements. So from a buprenorphine preparation standpoint, just what is available here in the US, for buprenorphine alone, there are 2 separate indications. So those for the treatment of opioid dependence specifically, those are the ones we're going to focus on, but there are a few that are available for the treatment of chronic pain as well. And if you've seen any of the, I believe starting at the end of February, there were a couple announcements about some shortages of buprenorphine. It was specifically for the solution for injection. So that looks like it's intermittently available depending on the manufacturer. It hasn't necessarily hit the other formulations. We also have the buprenorphine naloxone preparations. So you see the buccal and sublingual films as well as the sublingual tablets that are here. And these have the 2 concentrations because of the 2 medications that are involved. So since buprenorphine has a relatively low oral bioavailability, so we are looking at some different dosage forms to administer the medication. We'll start with the implant. And I was reflecting on this as I was reviewing this in preparation for this morning. It is a shame that this hasn't been covered more frequently or is readily an option for patients, because this might really be helpful for some patients that can be sustained on low dose. So they aren't having to go out to get prescriptions or anything like that. So it's been approved for maintenance treatment of opioid dependence in patients who have been able to be sustained for 3 months or longer on 8 milligrams or less of buprenorphine. So it is a relatively select population. They need to demonstrate that they're just fine on those doses that are relatively low. It is a surgical procedure. There are 4 rods that are inserted into the upper arm. They open in a fan distribution toward the patient's shoulder. These rods actually deliver medication over a period of 6 months. So they may continue to deliver just a little bit of medication after that 6-month mark, but likely it'll become subtherapeutic relatively quickly. So they're good for 6 months, and then at that point, either getting a different implant or looking at transitioning to a different form. Some of the more frequent are our transmucosal preparations. So the buccal administration, so on the inside of the cheek. So we have buccal films. These can be really beneficial, and as we'll look at, there may be an advantage for these over some of the sublingual preparations because the medication is getting delivered right through the buccal tissue, as opposed to sublingual where it may actually get dissolved in the saliva and unintentionally swallowed. So the buccal films have 2 layers, an adhesive layer and a backing layer. The backing layer really doesn't allow drug distribution back. It's going to be the layer that's between the cheek as well as the rest of the oral cavity. And it's really there just to protect the rest of the film. And all of the medication will be delivered the other way into that buccal tissue. So it will dissolve. It's important that patients, as they're putting it in their mouth, that their hands are clean but dry, because if they are wet, then it could potentially get stuck to their fingers and they wouldn't necessarily get the full drug delivered. This one does dissolve completely within about 15 to 30 minutes. And because it's on the side, we don't see as many taste issues as we see with some of the sublingual preparations. As far as administration, when they do have the buccal film in, it is recommended that they're not chewing or swallowing. If they do need to do a presentation similar to this, where they're going to be talking for a while, that may not be ideal, just because as their teeth and their tongue are moving, we don't want it to dislodge the film that was put in place. It's recommended not to have it anywhere if they do have any open sores or lesions in their mouth. They can either use their tongue to wet the side of their cheek, or even just take a sip of water and swish it around to be able to make sure that that's wet. With their dry fingers, they put it on the side, they say about 5 seconds, and then it'll be adhered right there. For the sublingual administration, so this is the one that's under the tongue, it is recommended that if they need multiple films or multiple tablets, that no more than 2 are placed. So one on either side of the tongue, as you can see here. There's not that much room, and as it gets dissolved, if there's too many of them there, it's more likely that the patient will swallow some of the dissolved preparation, so they're not actually going to get the full dose. With both of these, again, trying to avoid that food or drink as they swallow it, it could be reduced by 1/3 to up to 1/2. So it would essentially cut their dose in half, which would not be ideal for the patient. For the sublingual tablet, very similar. Just have them put it underneath. It'd be ideal if their mouth is relatively moist. Trying to encourage them not to chew or swallow. The film does dissolve much faster, and we'll look at that in just a second. The sublingual tablets do take a little bit longer to dissolve, and sometimes they do feel like there's a bit of a grainy texture underneath as it gets to the very bottom. But again, they should be encouraged not to. I would be bad at this because I'm one of those people, you put a Tic Tac in my mouth, it'll be there for a little bit, and then I just want to chew it and swallow it. So trying to ensure that they're able to be distracted so they don't do that. The last preparation from an administration standpoint is the subcutaneous injection. So patients for this need to be on transmucosal preparations for at least a week. And we do not have that threshold that we saw with the implant. So this is abdominal subcutaneous injections. So they do recommend the 300 milligram monthly for a couple months, and then there's a little bit of an option as far as which dose, and we'll look at what those concentrations look like. This is a gel. Once it's injected, the gel forms a deposit. It's recommended that the administration each month is rotated, so that deposit might take a little while for it to break down. So even though the gel has released all of the buprenorphine, the rest of the deposit's there, and it takes a while sometimes for the patient's body to break the rest of it down. So ensuring that we're rotating those injection sites so we don't end up with 2 deposits kind of one on top of the other. So we're going to transition a little bit into the pharmacokinetics because they are comparing apples and oranges a little bit as far as formulations are concerned. For our implant, once the rods are placed, they do start releasing buprenorphine right away. It reaches peak concentrations at about 12 hours. So they will see the drug concentrations rise relatively quickly. It reaches full steady state, so the level where the concentrations stay relatively consistent, the amount of drug being delivered, and the amount of drug being processed and eliminated by the body, it's relatively smooth, so it stays in the same range. That's reached by the end of the first month, and then those concentrations are maintained throughout the rest of that 6-month, 6-month window. And again, just as the reminder, it is equivalent to about 8 milligrams of the sublingual tablets daily. So if patients have needed higher doses, this may not deliver adequate concentrations. Looking at our transmucosal preparations, so I mentioned bioavailability is an issue. It's an issue even with the transmucosal delivery. So our buccal films that go on the cheek, they have the best bioavailability, so about 2/3 of the drug actually gets delivered. For the sublingual film, that would be the next most bioavailable with about 1/3 of the dose being delivered. And then our sublingual tablets, about 15% of it does get absorbed and delivered to the patient. For each of the preparations, by about 2 hours, they have reached peak concentration. So as it starts to get absorbed, it does reach peak concentrations relatively quickly after administration. And half-life for these does differ slightly, but it's about a day. And why is that important? Well, if we're making any changes, increasing, decreasing the dose, or even swapping between dosage forms, it'll take about 5 days for them to be at a new steady state. So checking in about a week to see, hey, is this working? Are we getting any side effects? What changes are there would be a good time frame. Just looking specifically at a couple of the parameters to compare the buccal film, the sublingual film, and the sublingual tablets. Now this information was taken from the package inserts. So in looking at sublingual film versus sublingual tablet, not only is the sublingual film more bioavailable, it does reach some higher concentrations, especially as those doses get a little bit higher. And that may be a result of potentially, like you see some of the 2 doses there, having those extra tablets underneath and maybe not getting the full delivery in dissolution with those sublingual tablets. And we see that even more exaggerated and consistent with the buccal film, achieving higher concentrations compared to the sublingual tablets. When looking at the films together, the buccal film, excuse me, does have a little bit of a higher maximum concentration, especially at some of those higher doses compared to the sublingual film. So in patients who really need a higher dose or a higher concentration in order to control their symptoms, that seems to be a little bit more advantageous. And because there is that difference between the sublingual tablets and the buccal film, there is a dose conversion because it's not one-to-one. We're seeing significantly different, more drugs being delivered, we get higher concentrations, so maybe we don't need to use as high of a dose. So you do see that it's almost half for the buccal film as compared to the sublingual tablets. And again, if we have to switch between things, that would just be something to keep in mind. There is one sublingual tablet product that does stand out compared to the other ones. So the Zubsolv in particular is manufactured using a little bit of a different technique. So it's prepared using what's called dry mixing and direct compression. So the way that they're able to combine the ingredients and create those sublingual tablets, they get lighter tablets that can dissolve much quicker. So we actually see similar concentrations at lower doses for the Zubsolv compared to the other sublingual tablets. So they dissolve quickly and a little bit more of it is able to get absorbed for the patient. Last piece is looking at the subcutaneous injection. So this also had come from the package insert. And I think this is helpful to see because the first 2 columns under Subutex, so our buprenorphine, patients who are on 12 milligrams or 24 milligrams, and then you see the average concentration and then the maximum and minimum concentrations. The last 3 columns are for the subblockade. So with the first injection of 300 milligrams, and then for patients that were stabilized and given monthly 100 milligrams or 300 milligrams. So as you'll see, even for patients that were on 24 milligrams of buprenorphine transmucosally, their average concentration is about just under 3. And if they're given the monthly 100 milligram injection, you see that their average concentration would be just over 3. So really able to maintain those patients that require a little bit higher concentrations, even with the 100 milligram. I did not reach out this time, but I had been asking, there had been some interest in looking at different doses for the subblockade as opposed to just having the 100 and 300 milligrams available. So I know that there had been interest and there was some suggestion that they were looking at that, but I haven't seen anything come through recently, although I did not reach out directly this time. And with that, There's a couple other slides, just supplemental information, looking at this pharmacokinetic pieces, and I will stop share.